Hello, my name is Paul Fletcher. I'm a periodontist and associate clinical professor at Columbia University, where I teach implant dentistry and periodontics on a postgraduate level. This video is being placed on YouTube at the request of those who have attended my lecture on the management of peri-implant disease. It summarizes the slides of the presentation so they can review the material at their convenience. The video will also be valuable to any dental professional who desires to learn a research-based, in-office and at-home protocol for the treatment of peri-implant mucositis. And the final 10 minutes will be of special interest to any patient who's been told they have bleeding or they're beginning to lose bone around their dental implants. Peri-implant disease is a very controversial topic. There are some excellent clinicians and researchers who don't feel they see peri-implant disease all that often and it's just a minor inconvenience, where there are others who think it's becoming a major problem. I'm one of those who are beginning to feel we have a problem. I feel we have a problem because at Columbia University, hardly a week goes by when another student doesn't approach me with a new case of peri-implant disease. And in my private dental practice, where literally half of the new patients we see are due to some form of implant-related issue, we're also seeing the number of new cases of peri-implant disease increasing. The research also seems to say we have a problem. The research is telling us as the number of implants that have been placed increases, and as the number of years implants have been in place increases, and as dentists with different skill sets are beginning to place implants, the incidence of peri-implant disease is increasing and the prevalence of peri-implant disease is increasing. Difficulty is that the implant research is very confusing because study methodologies vary. Some studies say they talk about different thresholds for peri-implant disease. Other studies put together different surfaces and designs and equate them. And finally, some studies look at patients with peri-implant disease, whereas other studies look at implants with peri-implant disease. And finally, some studies look at implant survival and equate it with implant success. So if we take a look at these implants over here, these implants were placed 13 years ago. When we take a look at them 13 years afterwards, we can see the amount of bone loss around the implants. Now, they definitely survived, but I'm not quite sure we can call these implants a success, but I do know that they definitely need treatment. From a historical perspective, we also have a problem. Periodontal indices, such as bleeding upon probing and pocket depth, were originally felt when applied to the peri-implant mucosa may be of little clinical significance when measuring the success or failure of osseointegrated implants. And they also said, the early research, peri-implant disease is rare. Attached gingiva is only needed if the area is inflamed. Well, the early research was looking at smooth surface implants where the implant abutment junction was above the soft tissue in the crest of bone. And in today's world, we're using rougher surface implants where the implant abutment junction is right at the surface of the bone. And I'll tell you, in every lecture that I present, there's always somebody that asks me if it's okay to probe their dental implants. And it's definitely okay to probe your dental implants. It's very important, in fact, that you do gently probe around your dental implants. From a microbiologic perspective, we also have an issue because implants are being placed in patients with active periodontal disease. And the bacteria that cause periodontal disease also cause peri-implant disease. And patients who lost their teeth due to periodontitis have an increased risk of developing peri-implantitis, and we know that at this point in time. From a histopathologic level, also we have a problem because the attachment apparatus around the tooth shows inflammation at this point, and we have perpendicular connective tissue fibers attaching into a tooth. And you also have a periodontal ligament around the tooth where anti-inflammatory cells can migrate out of the periodontal ligament to help prevent the spread of this inflammation. Whereas around an implant, we don't have these perpendicular connective tissue fibers, and we also don't have a periodontal ligament. Thus, the apical extension of the inflammatory cell infiltrate is more widespread, and it extends into the alveolar bone around the implants. And the peri-implant tissue is less able to arrest progressive plaque-associated lesions. If we take a look at this histological photograph here, we can see the parallel or circular orientation of the connective tissue fibers may lead to a more rapid spread of the inflammation in the perimucosa. And because we get this more rapid spread, we see rapid bone loss very, very, very quickly. So if you take a look at this case here, these implants were placed in the year 2000. In 2008, you can see the levels of the bone are still high. In 2011, the patient returned to our office, and you can see the beginnings of peri-implant bone loss. She got lost. We didn't treat her. She came back 3 years later, and take a look at the additional amount of bone loss that had occurred just in that 3-year period. This is a problem. Because of this bone loss and this rapid bone loss, you can see the type of bone loss we get is very aggressive around these dental implants. We don't see bone loss like this around the tooth. Around the tooth, you may have bone loss on the mesial of one tooth or in the distal of another tooth, a vertical defect. Around implants, we get this circumferential bone loss completely around the tooth. 360 degrees. Another problem we have is the growth of oral biofilms are facilitated by the screw-shaped design of the implant, the design of the superstructure, and the surface modifications, be it the rough surface of the implants. So we take a look at this case here, and all of us have implant cases like this. There's no way that this patient can get underneath this framework to keep this area clean. This is a problem. The weak links are the surface and the implant abutment junction, and the adhesion of microbes to bare and rough implant threads impedes mechanical cleaning. So you take a look at this photograph over here, and you can see plaque and calculus in the threads of this implant. Now, our normal curette can't get in there to clean this area. The normal root planing motion is occlusal gingival. In this case here, you have to go circumferentially around the threads of the implant. And if this area wasn't flat back, you wouldn't even be able to realize or recognize that you had plaque and calculus in the threads of the implant. The implant abutment junction is also a problem because it's been shown that micro-leakage occurs into and out of both internal hex and Morse taper connections. In today's world, that implant abutment junction, more often than not, is right at the crest of bone. So you can see the space here around this implant abutment junction. And as the patient chews, that area flexes and bacteria pumps in and out of that implant abutment junction, causing issues. Cement is a real problem. It's been shown that in this case, by Wadhwani and Pinheiro, they looked at 185 failed implants, and they found residual cement, excess cement, when they looked at it under magnification in 65% of those failed implants. This is a problem, and you can see the cement on this implant over here causing the amount of bone loss that it caused around that implant. That's a problem. Bottom line is, if the patient has a problem, you have a problem. And now we have to talk about how we go and deal with managing that problem. So when we talk about the definition of peri-implant disease, peri-implantitis is a destructive inflammatory reaction affecting the soft and hard tissues of an implant in function. And in other words, besides affecting the gum, it affects the bone, and there's a bone loss. And there's bone loss. On the other hand, mucositis is a reversible inflammatory reaction in the soft tissues surrounding a functioning implant. The key word here is reversible. So if mucositis can be reversed, the important thing to realize is treating mucositis will prevent peri-implantitis. Plain and simple. So let's take a little bit more of a look at mucositis so we can get a little bit of a better understanding of what's involved and what the signs and symptoms are of mucositis. So mucositis is a reversible inflammatory infiltrate in the soft tissues surrounding a functional implant. The clinical signs are inflammation, bleeding upon probing, 4+ millimeter pocketing, and possibly suppuration, pus, but there's no progressive bone loss, when you take a look at an x-ray of an implant with mucositis. So as far as suppuration is concerned, if you probe 5 or 6 millimeters and you see no bleeding, it becomes important that you palpate the gingiva around that implant surface, because many times you'll see purulence coming from that sulcus and that pocket depth. And this is because when you get to 5 or 6 millimeters, the bacterial flora changes from an aerobic flora to an anaerobic flora. And that's why at 6 millimeters and 5 millimeters, you may start to see pus coming out from a pocket around an implant. Finally, radiographic bone loss is stable after 1 year of functional loading. There is no progressive bone loss after the first year with mucositis. Those are the signs and symptoms. Now, when we take a look at an implant with mucositis or peri-implantitis close up, and this is a scanning electron micrograph, what we see here are the pores of the implant, and this is bacteria attached to the implant and embedded in between the concavities of this implant and the pores of the implant. There's no way that you can get in there mechanically to remove this bacteria. It's embedded. Mechanical therapy alone is inadequate to predictably detoxify an implant surface. That means that cleaning an implant surface is not a monotherapy, but it's a bitherapy. And besides mechanical cleaning, what we get involved in is chemical detoxification of the implant surface. So the goal of our treatment is surface decontamination, both mechanical and chemical. And our objectives are basic microbiological objectives: disrupt the bacterial plaque biofilms, detoxify cell components affecting the growth on the implant surface, and reduce the bacterial load by dilution to a level that will allow healing. Basic microbiologic principles: dilute, disrupt, and detoxify, with our objectives and our goals being to eliminate bleeding upon probing, the primary objective, reduce pockets if possible, and stabilize bone levels. And that's what we're looking to accomplish when we treat these areas mechanically and chemically. Now, what we need in dentistry, as far as I'm concerned, is we need a readily available, low-cost method to detoxify an implant surface so that people all over the world can have access to these materials and medicaments to detoxify the implant surface. Now, as far as surface decontamination is concerned, mechanical and chemical, the research talks about a lot of different ways to detoxify an implant surface. There are mechanical ways and there are chemical ways to do this. But some of them, like the laser, are very expensive. There are many, many practitioners around the world that can't spend $75,000 to $100,000 on a dental laser. So we have to come up with something that's low cost and readily available. And as far as those different ways to detoxify an implant surface, Esposito said it so well in 2012. What he said is, while there's no reliable evidence suggesting which is the most effective treatment for peri-implant disease, that doesn't mean that currently used treatments don't work. So let's take a look at what we're using, what I'm going to suggest that you use to detoxify the implant surface. First, we're going to be using curettes. Now, some curettes are problematic, such as stainless steel curettes. The curettes have to be softer than the implant because a metal curette, such as stainless steel, will alter the implant surface. It will cause damage to the oxide layer, and it affects the surface chemistry of biocompatibility, and it will scratch the implant. And surface roughness will influence plaque growth. And we've seen that multiple places and multiple times. So you have to use a titanium curette, which is equal in hardness to the titanium implant, a plastic curette, gold curette, or even a carbon fiber curette. But we're going to use curettes to mechanically help detoxify the implant surface. From a chemical standpoint, what we're going to use chemically is something very simple and readily available worldwide, an excellent antiseptic worldwide, and it's sodium hypochlorite for chemical irrigation. But we're going to use a highly diluted solution of sodium hypochlorite, which is straight household bleach. 0.5 to 6% household bleach. But looking at sodium hypochlorite, what it's been shown to do is there's an 80-fold decrease in the biofilm endotoxin when compared with water. It's present naturally in neutrophils, macrophages, and monocytes in our blood cells, so you can't be allergic to it, and it can't be carcinogenic because it's in the body. And there's no visible histological effect on periodontal healing that's been shown in the literature. It does not corrode titanium implant surfaces, and it's been accepted as a safe mouthwash, by the American Dental Association. So all of these things are good, and it's a highly cytotoxic antiseptic. This is good, and this is what we want to use. So to make a 0.25% sodium hypochlorite solution, what you're going to do is you're going to mix 5 milliliters, which is 1 teaspoon, of household bleach, 5 to 6% sodium hypochlorite, in 4 ounces or 125 milliliters of water. Now, 4 ounces of 125 milliliters of water. The standard drinking cup that we use for our patients has 5 ounces or 156 milliliters of water. So if you put in 5 mLs or 1 teaspoon of household bleach in one of the standard patient drinking cups and fill it 4/5 of the way with water, you will wind up having a 0.25% solution of sodium hypochlorite. Then we take a blunt end monojet syringe, 23-25 gauge needle with a blunt edge, and you fill the syringe with the sodium hypochlorite, and you irrigate around the surfaces of the implants subgingivally. And that's what we're going to be using in our chemical irrigation process. And the treatment approach we're going to use is cumulative interceptive supportive therapy, originally written about by Lang, Mambelli, and Berglund in the early 2000s and the late 1990s. And what it is a sequential additive approach to treating peri-implant disease. And it starts out with mechanical therapy. And as things become more problematic, it adds antiseptic therapy, then antibiotic therapy, and then surgical therapy. So with pocket depths 3 millimeters or less without plaque or bleeding upon probing, or even with bleeding upon probing and plaque, you use mechanical debridement and polishing. Treatment A, just simple mechanical debridement. When you get to pocket depth of 4 to 5 millimeters and you have bleeding upon probing, you use mechanical debridement, and then you add the antiseptic therapy or the sodium hypochlorite. And we use that into the mix with bleeding upon probing when you have 4 to 5 millimeter pocket depths. As you get greater than 5 millimeters in your pocket depths, you'll use your antiseptic therapy, which is B, and you may add your antibiotic therapy, which in this case can be either systemic or local antibiotic therapy. As things get worse, you think about adding surgical therapy to your treatment approach. So what we're going to use for local delivery of antimicrobials will be minocycline microspheres, or Arrestin, when we need it. What they do is the Arrestin is highly cytotoxic, and it will really kill almost all of the bacteria involved in the main bacteria in the spread of peri-implant disease, and it produces 1,000 times the minimum inhibitory concentration of antibiotic for 5 days, 100 times for 14 days, and it shows improvements in pocket depth, bleeding upon probing, and microbiology at 6 months, but not 12 months. But we don't even need it to be effective for 6 months, because we're going to be seeing our patient every 3 months, and we'll talk about that as we move forward. And pocket depths are only an improvement in the range of 1 millimeter. We don't see a lot of pocket depth improvement, but we do see improvement and elimination of bleeding upon probing. So this is the in-office protocol that we're going to follow for the management of peri-implant mucositis. In-office regimen, maximum recall, 3 months. As I said, with 3 millimeters and no bleeding upon probing, gentle probing for resistance, evaluate plaque levels, prophy cup and polish. When you get to 4 to 5 millimeters without bleeding upon probing or separation, same thing, just continue to mechanically debride with a curette. You can use an air polisher if you so choose to, but when you get to 4 to 5 millimeters with bleeding upon probing or greater than 5 millimeters with or without bleeding upon probing, what we're going to use is our mechanical therapy, and then we're also going to add our chemical therapy, which is the sodium hypochlorite irrigation. And you're going to irrigate before you start debriding mechanically, and you're going to irrigate during the debridement mechanically, and then after you debride mechanically. And the reason for this is the crevicular fluid changes over every 90 seconds. So every 90 seconds, this is being washed out by the crevicular fluid, and you have to get it in there and re-irrigate. So during the course of irrigation, for a total of 5 minutes, that's what you're going to do. You then apply pressure, and you apply pressure for 1 minute because you've cleaned the surface of bacteria. And epithelium and connective tissue will adhere to any clean surface. So you then apply pressure for a minute to get epithelial readherence of the soft tissue to the implant surface. You send the patient home and give them a home care regimen to use, and we'll talk about that in a minute. And then you see the patient 3 months afterwards. And when you see the patient 3 months afterwards, you reevaluate. And if they still have 4 to 5 millimeters with the bleeding upon probing or more, you repeat the initial therapy, and then you add the minocycline microspheres, or the arrestin, into your protocol. You add the next part of the cumulative interceptive supportive therapy and apply pressure. You apply pressure again for a minute. You send the patient home, have them do their home care regimen. The patient comes back 3 months later at a total of 6 months at the 6-month reevaluation. And if you continue to see the bleeding upon probing, the next thing we're going to do incrementally is we're going to remove the restoration and detoxify the underside of the restoration, because that's probably contributing to your problems. So, maintenance protocol, restoration removal. You remove the prosthesis if feasible. And once you do that, you remove the plaque, you use sodium hypochlorite, steam clean, air polish, or sterilize the underside of this restoration along with the screw access opening. All right? Then you also detoxify the platform and screw access opening on the implant. And you'll take a cotton pellet with sodium hypochlorite and you go right around the platform of the implant and put sodium hypochlorite irrigation into the screw access opening. Then you gently curette the pocket lining to remove any granulomatous tissue or epithelium that's down there. You replace the restoration and you apply pressure for 1 minute. So when we take a look at this case that we've been showing you all along, removing it, this is the before with the 6 or 7 millimeter pocketing and the bleeding upon probing and the inflammation. And this is what it looks like 6 months post-treatment. You can see we've reduced the pocketing, the bleeding has been significantly reduced, and the inflammation is gone. Let me show you another case. This patient really was doing everything she could possibly do to keep this area clean. But it was probing 8 millimeters with bleeding upon probing, maxillary molar area. We take a look at the x-ray. This is a sinus lifted area. There's been no bone loss. But when we remove this restoration, take a look at the amount of plaque that was underneath this restoration sitting on the tissue, waiting to ultimately cause peri-implant bone loss. If the patient's host resistance gets low, this area would start to break down periodontally because of this plaque sitting right on that soft tissue. What we subsequently did is, and here you can see what the area of mucositis looks like and the inflammation when the restoration is removed, as opposed to this area which is healthier. And what you do here is you curette this area, you irrigate, and you also remove the endotoxin with a cotton pellet from the platform of the implant. You thoroughly clean the underside of the implant with the sodium hypochlorite, and now what we're using an air polisher or whatever we can do to clean off any residual areas here, but we'll clean that very thoroughly. We then take the implant restoration, put it back in the patient's mouth, and apply pressure for a minute. And this is the 1-year follow-up. Now, if you take a look over here, no longer bleeding upon probing, healthier tissue, still 5 millimeter pocketing. because in the maxillary molar area, many times we start out with 5mm pocketing. So we have 5mm pocketing just anatomically, and it has to be maintained and followed. But again, 5mm pocketing, no bleeding upon probing at the 1-year follow-up. Here's another case underneath the framework of an implant. This patient came in with a soft tissue abscess. She was unable to keep the area clean. We removed the framework and take a look at the inflammation around all of the implants, even where there wasn't an abscess. So what we subsequently did is we wound up cleaning the underside of this implant very thoroughly. In this case, we used a cotton pellet with hydrogen peroxide, which can be used also, 50-50 dilute hydrogen peroxide when you take these frameworks off, to get totally around the implant and in between the implant surfaces, into the screw access opening, to thoroughly clean totally as much as you can around the framework and into the screw access opening. We relieved the area that was inflamed and had the abscess on the acrylic. We placed the restoration back in the patient's mouth, and this is the 3-month follow-up. As it turns out, we had to remove this framework for a prosthetic repair, and when we removed it, I took a look at the implants in the implant abutment junction, and you can see the difference in terms of the way the tissue looked here as opposed to the way it looked originally. And as I say when I lecture, this isn't magic. This is purely biology. You remove the bacteria, the tissue will heal. And that's what we have to try to do. So, finally, at-home prevention and treatment of mucositis. It's all about controlling the biofilm. That's what's most critical. And you have to tell the patient, our objectives are, we've cleaned the underside of the implant, the subgingival aspect of the implant. Your responsibility is now to stop the supragingival bacteria from migrating subgingivally. So objectives are minimize subgingival migration of supragingival biofilm and keep the subgingival biofilm below an inflammatory threshold. That's what we're trying to accomplish. And here's the at-home regimen. Optimal home care is imperative, and you have to explain that to your patient. I find implant patients to be much more compliant than my periodontal patients. These patients have lost their teeth. They spent a lot of money and time getting them replaced with implants and implant restorations. And now you're telling them they may be in danger of losing the implants. So most of them are ready to do anything they can to maintain the implants. And what we're asking them to do is really basically something very simple. All we're asking them to do is brush their teeth and rinse their mouth out. And we're asking them to brush with the triclosan dentifrice. This is Colgate Total toothpaste in the United States. Triclosan dentifrice, the Total, has been shown to reduce inflammation, bleeding upon probing, and 5mm pockets over the course of 6 months. Again, we're seeing the patient every 3 months. There's less plaque, there's reduction in gram-negative anaerobes also over 6 months. Much research on it. We're also asking the patient to rinse their mouth out with a mouthwash. And they can either use an essential oil mouthwash such as Listerine or acetylpyridinium chloride mouthwash such as Colgate Total mouthwash. The essential oil mouthwash, research shows less plaque and bleeding upon probing than a control, but no changes in probing depth. But we are reducing the bacteria. And the good thing about the CPC mouthwash, it has 12 hours of substantivity. It stays on the mucous membrane surface, and there's no alcohol. You want to use that in patients that can't use alcohol. Essential oil mouthwash, you have to use the Listerine that has alcohol in it, so to speak. So here's the home care regimen. As I said, optimal home care is imperative. The patient is to brush with triclosan toothpaste twice a day, morning and evening right before they go to sleep. Definitely right before they go to sleep. And then rinse with the essential oil or CPC mouthwash twice a day. Once again, with one of the rinsings being right before they go to sleep at night. Because what happens is bacteria multiply when the salivary flow is reduced. So right before you go to sleep, it's necessary to do. The toothpaste will, in fact, clean the area around the implant, whereas the mouthwash is going to take care of the bacteria on the mucous membranes, on the soft tissue, in the back of the tongue, and on the throat. If you can get the patient to floss, use an end-tuft brush or interproximal brushes, even better. And the final thing you're going to have the patient do is, if they have a framework in their mouth that's difficult for them to get under there and keep clean, you're going to give them a monojet, plastic monojet syringe with a plastic needle to take home, or a plastic tip to take home. And you're going to tell them to irrigate with sodium hypochlorite in the monojet syringe 3 times a week around and under the frameworks. And the concentration you're going to tell them to use is, you're going to tell them to take 1/2 teaspoon of sodium hypochlorite, which is 2.5 milliliters, just a 1/2 teaspoon, and you're going to tell them to put it into 16 ounces of 500 milliliters of water and make that type of solution, and then use the monojet syringe to irrigate as best they can under the frameworks of the implants. And that's what we tell our patients to do in order to treat the mucositis. To summarize, early interceptive treatment is imperative in the patient prone to periodontal disease, especially. And the best treatment for peri-implant disease in 2015 is prevention. So I can't emphasize enough how important it is that you give the patient an at-home regimen for brushing around their implants and treating their mouth to prevent mucositis from progressing to peri-implantitis. So I hope you got something out of the presentation. Feel free, if you have any additional questions, to contact me, Specialized Dentistry of New York, at pfletcherdds@gmail.com, and my phone number is 212-752-7937. I'll be more than happy to answer any questions you may have, and I hope you got something out of this presentation.